All right, thank you, Cindy, for the introduction, and congratulations on the 10th anniversary. So today I'm going to be discussing a little bit about Morgellons disease testing and diagnosis. I know there are a lot of questions out there for those of you with Morgellons disease who may have had Lyme testing done and may have come back negative. So the purpose of this presentation is really to address why your test may have come back negative and to really encourage you to move forward with further testing. So this is my disclosure statement. I have no conflict of interest. We're not doing CME credit. So again, just a little bit of an overview of the presentation. First, I'm going to be providing a definition for both Morgellons disease and Lyme disease. In order to understand testing, so all the things that we've been hearing about over the last couple days, all the molecular tests, you really do have to have a sound understanding of Borrelia species as a whole. Otherwise, discussing strains and genotypes can be very confusing. So I'm going to go a little bit into the types of Borrelia that are out there and really give you the opportunity to understand why your test may have come back negative. I'm then going to do a little brief overview of the immune response, the differences between how men and women actually respond differently to infection. We're then going to talk about the basics of some of the Lyme disease tests out there. Again, I'm not going to go into specific detail, otherwise I think I would bore a lot of you. And then what we're going to be doing is looking at the CDC recommended tests, which are known as kind of the horrible coin toss tests. And then I'm going to compare Lyme testing versus HIV testing. The reason being is HIV testing, it's so good, and I think that Lyme testing really needs to get to that point. So just a little background on Morgellons disease. I'm sure you're sick of hearing about this, but Morgellons disease, it's a complex skin disorder characterized by ulcerative lesions that have protruding or embedded filaments. So this is really in part from an atypical production of keratin and collagen. So your keratinocytes and fibroblasts that are located within your skin just overproduce or atypically produce these natural proteins that can come out of the skin, so it can feel like crawling, it can feel like stinging. You can get these spontaneously appealing ulcers from these things breaking through the skin. So Morgellons disease, it is associated with a persistent Borrelia infection, possibly just a spirochetal infection as well, and there are these other multiple components. About 6% of patients with Lyme disease will go on to develop Morgellons disease. So again, this is a true somatic illness. This is not a delusional disorder. So there is true delusions of parasitosis. That really is a true diagnosis. But those of you out here in the room, you do not have that. You have Morgellons disease, which is a dermatologic condition associated with an infection. So how do we diagnose Morgellons disease? Well, I won't get into all the background. I think Dr. Savely got into that. But first of all, you have to be examined by a qualified healthcare professional. So using a handheld microscope, anywhere from 40 to 100 times X, you can actually visualize fibers and or these black specks embedded within the dermis. And that was really what's distinguishable about this condition. So now, what I'm going to do moving forward is talk a little bit about Lyme disease. So Borrelia burgdorferi is the causative agent of Lyme disease. It's known as a spirochete. The reason it's known as a spirochete is it does form this kind of spiral-like structure you can see in the lower left-hand corner. And it is transmitted by the bite of a tick. Ticks have been called sewers of infection. Anything they feed on, they can pick up and transmit to you. So there are oftentimes these co-infections that also go along with a tick bite as well. Karsten Nicholas, he just talked a lot about co-infections that include Babesia, Bartonella, Ehrlichia, Anaplasma, and Rickettsia. So there are a lot of different bacteria that you can also get from a tick bite. Just to give you an idea, there was a study done in China about 2 years ago that looked at their tick. Their tick had 237 types of microorganisms in it. Now, not all are pathogens, but it just goes to show you what you're exposed to when you're bitten by a tick. There are also some novel viruses. I think a recent recent study showed about 6 different viruses have been found in ticks recently that we really don't know about as well. So the CDC now estimates there's around 380,000 new cases of Lyme disease diagnosed here in the States every year, so that's almost 7 times as common as HIV and over twice as common as breast cancer. So this is a huge epidemic. Now, the number provided by the CDC, that's based off surveillance criteria only, so this probably grossly undermates the actual amount. And just remember, 6% of these patients will go on to develop the dermatologic condition associated with Lyme disease called Morgellons disease. So I like this picture because it kind of shows you this is how small the Borrelia bacteria is. Those are red blood cells. This is the types of relapsing fever Borrelia, Borrelia hermsii. Again, the relapsing fever Borrelia like to be in the bloodstream, and hence they can cause these relapsing fevers, versus the Lyme disease group, it likes to be in tissues, so you don't usually get that relapsing fever. But I'm going to go and kind of discuss a little bit about the difference between these two groups. A lot of patients, they think that the stuff coming out of their skin is the actual spirochete itself. It is not the spirochete. You cannot see it with the naked eye, so this is very microscopic. So just to give you an idea of where the spirochetes fall, so the 3 domains of life, you have the bacteria, archaea, eukaryotes. We fall in the eukaryotic family. Spirochetes are in the bacteria family. So I'm just going to start from a very kind of basic perspective of Borrelia. So the scientific classification of Borrelia, you can see again domain bacteria, and as we kind of work our way down from phylum, class, order, family, we then encounter the genus. So that's the Borrelia bacteria. So that's a genus of bacteria. Now, as far as the species goes, so species, when we talk about species, we're talking about Burgdorferi, Hermsii, Miyamotoi. So these are all different types of species of Borrelia bacteria, and there are at least 52 species of Borrelia bacteria. So when we think about testing moving forward, the testing does not always pick up all these different species, and a lot of these species cause very overlapping symptoms to Lyme disease, and I'm sure a lot of you maybe have a species that's just not detectable by testing. So the Borrelia species, so the ones that are known to cause Lyme disease are collectively called Borrelia burgdorferi sensu latu. So if you ever hear of the sensu latu group, this is the Lyme disease causing group of bacteria. It's typically broken down into the New World, Old World, and then a combination of both. About the 3rd point down, you could see Borrelia burgdorferi sensu stricto, so that's kind of the classic Lyme bacteria that we know of and that we refer to. But you can see there are a lot of other different species of Borrelia that can cause Lyme disease. So I do want to make that clear. There are also emerging genospecies, so these are just other species of Borrelia like Lostari, Mayoni, and Miyamotoi. Of course, the Mayo Clinic recently discovered Borrelia mayoni, and it was this huge deal that they discovered this new species of Borrelia. I think they kind of forgot that there are a lot of other ones out there too. So this is a nice map. This is looking at the sensu latu group. So again, this is the Lyme disease causing group. Up at the very top with those orange arrows, you could see the Borrelia burgdorferi sensu stricto, and you could see it's found throughout the Americas and in Europe as well. But it just gives you an idea that there are a lot of different species of Borrelia that are found worldwide. So again, the classic Lyme bacteria, the Borrelia burgdorferi, there are 5 subspecies. Now I'm going to start talking about strains. Now a strain is a genetic variant or subtype of a particular bacteria, so they vary genetically. So in the USA, there are over 100 strains of Borrelia burgdorferi. In the world, there are over 300 strains of Borrelia burgdorferi. So this is where we run into some issues with testing. So with testing, what we're doing is most commercial test kits look at one strain of Borrelia burgdorferi, and that is the B31 strain. So this strain, it's considered a lab strain at this point because it's been stabilized in culture for so long that it doesn't even resemble the wild type Borrelia anymore. So if we look at this graph over here, you can see all the way on the left side that it says Lyme disease group, and then below that the relapsing fever group. That all branches off, and where I wrote strain in the red in the upper corner, those are all different strains. So you can see there are a bunch of strains of Borrelia burgdorferi, and then going down into the relapsing fever group, we have Borrelia miyamotoi, Borrelia hermsii. So again, the testing, most commercial test kits only look at one strain, and there are over 300 strains of one species of Borrelia bacteria worldwide. So the odds of testing positive is very slim unless you're using a good laboratory that looks at multiple species and multiple strains of Borrelia. So again, this is just that one strain, strain 31, that commercial strain. It has one of the largest and most complex genomes known of any bacteria. It actually has 9 circular plasmids and 12 linear plasmids. Now, when I talk about plasmids contain genetic material that allow for genetic exchange between different species. So one Borrelia species could transmit genetic material to another species. And this allows for pathogenicity. It also allows for the development of bacterial resistance as well. So again, this is a very complex organism we're dealing with a lot of different species and a lot of different strains. So not only is it genetically diverse, Borrelia contains many different forms as well. So you probably have heard of forms of Borrelia. So Borrelia is considered pleomorphic because it has so many forms. So there are a lot of different morphologic variants. So here's just a little quote from one of the great papers that was published on these forms. Borrelia burgdorferi sensu latu is pleomorphic, being able to change its morphology as response to environmental conditions. So as practitioners treating this condition, you do have to use various antibiotics to go after these certain forms of Borrelia. So again, this ability to change shapes allows the bacteria to evade the immune system. It decreases its antibiotic susceptibility, and it can change its pathogenic mechanisms. And again, these different forms actually express different antigens. And again, that can produce a different immune response. So when it comes to testing, when we're doing indirect testing, you might not be able to pick up an active infection because you have these different forms. So those pictures over there are kind of nice. So the upper left picture, that's actually the spiral form. The picture on the upper right, those are also spirochetes with a couple blebs. I'll talk about those in a second. The picture in the lower left-hand corner, those are round bodies. And the picture in the lower right corner, that is a biofilm-like aggregate of Borrelia bacteria. So here's the paper that I was referring to. It's the pleomorphic forms of Borrelia burgdorferi induce distinct immune responses. And so you can see there, those are all the different forms of Borrelia that have been classified. You have the spirochete form that we're all very familiar with. It kind of cruises amongst tissues. We have a bleb form, a round body form, which actually lacks a cell wall. And then we have the biofilm-like colonies as well. So down at the bottom in the red, spirochetes and round bodies, they both have completely different protein expression, and so therefore they have different antigenic properties. And you can actually see this in an immune response. So you actually elicit a different immune response depending on which type of form of Borrelia you have. So the results of the paper, they indicate that round bodies have the ability to induce distinct immune responses compared to spirochetes, and that could actually be associated with different clinical symptoms in patients. So let's just talk quickly about the immune system. I don't want to go too in depth. The most important thing that I want you to get out of this is when we do testing for Borrelia, we use some tests called indirect tests that again look at your antibody response to an infection. So this image, it shows a spirochete in the upper kind of left-hand corner, and you could see that there are these cells called B cells producing these antibodies. They look like those Y-shaped things. So those are considered immunoglobulins, and that's what a lot of the testing is picking up. So when you have an infection, you're making antibodies against this infection, and so that's what a lot of the lab testing is looking for. Are you making an immune response against an infection? So what's interesting, if you've had any biology class, any immunology class, if you've gone to medical school, nursing school, you learn that IgM, which is kind of this acute phase antibody, is only produced within the first month of the infection, and then goes away and seroconverts into an IgG antibody. So we'll be talking about this a little bit later, but what I want you to realize is that the textbooks, I hate to say it, but some of them are wrong. There's a lot of literature out there showing that IgM can actually be produced throughout the entire course of an infection. This has not only been demonstrated in Borrelia, it's also been demonstrated in Pseudomonas infections and mycobacteria. So keep in the back of your mind, if ever you go to a doctor and they say, oh, you have a positive IgM response, that should only be positive during the first month of infection. If after that month it's still there, that's a false positive, so you therefore don't have this infection. So just keep that in mind, that it just doesn't play this way. These infections did not read the textbook. So let's move on. So another interesting part about the immune response is women and men actually elicit different immune responses. There have been some recent studies looking at vaccinations as well. So women and men respond differently to vaccines. So it's interesting. So women may develop more significant symptoms than men because they produce more cytokines or more inflammatory mediators. But men, though they don't have as many symptoms, they actually will produce more positive serology. So for example, you may have a very sick woman who's very symptomatic, and her testing may be completely negative because she's not producing this huge immunoglobulin response. Whereas in men, you may have a man who doesn't have very many symptoms, but his serology may be quite positive. The reason being, it all comes back to women have to be pregnant, and you don't want to attack the fetus. All right, so let's get into testing for Borrelia. And again, those of you with Morgellons disease, we know that Lyme disease is one of the underlying infections that we've seen a lot of. So most practitioners will want to test you for Lyme disease or Borrelia if you present with Morgellons disease. So going back to the different types of testing, so we have direct testing and indirect testing. Direct testing is looking for, can we look for that actual bacteria? Can we find the bacteria in this sample we have collected? So certain types of direct testing include culture, microscopy, PCR, dot blot fish. Again, I'm not going to get into every single testing available out there. These are just examples. Indirect testing, on the other hand, is looking at your immune response against that bacteria or antigen. So again, we're looking at antibodies. So think about the gender bias that's present in that. Types of indirect tests include Western blots, ELISAs, or EIAs, or IFAs. Another important thing moving forward to realize, you've probably heard a lot about sensitivity and specificity, and they can be very confusing if you don't quite understand the difference. They're both very different, but very important. So the best tests should have both high sensitivity and high specificity. And what we've learned is a lot of the commercial tests out there have really high specificity but low sensitivity. So a test that is low sensitivity means they have a lot of false negatives. So those are a lot of the commercial tests. So what we want is high sensitivity, meaning there are few false negatives, and we want high specificity, meaning there are few false positives. So when you do start to explore different testing options, please be aware of these two things. There are tests out there that don't have any published literature on specificity and sensitivity, so you do want to be very careful with where you order tests from. So I'm just going to go briefly over the different types of direct and indirect testing. So as far as culture, again, we're basically growing the bacteria in a medium. As of right now, that's only offered at one laboratory from what I'm aware of. The pros of this is that it's considered the gold standard of detection. So basically, if you can grow the bacteria, it is there. Nonetheless, the CDC, it advises caution when using this. They usually say that the lab that's performing this procedure, there might be contamination. So if you were to culture the bacteria, it may be a false positive. So the cons of this is if you don't grow the bacteria, it doesn't mean it's not there. It just means that the sample you collected did not contain the bacteria. And again, Borrelia is very slow growing. It can take weeks to months to culture the Borrelia bacteria. So microscopy, Marianne Milvine does great microscopy. She basically has a microscope. She usually uses dark field and can visualize the bacteria under a screen. There are also certain staining techniques that you can use to stain specifically for Borrelia, so you know indeed you are looking at Borrelia rather than another spirochete or something that has similar structure or form. So again, this is kind of the downside, is that this isn't offered by any lab. So for those of you who are interested in having this done, this is just not offered out there commercially. You have to go to some private university. So again, the pros are, if you see it, it is there, and the cons, the bacteria may not always be visible in the sample depending on where you're getting the sample from. So you can get samples usually from blood or from culture. And again, there's a lot of variability between strains as well, so, or with stains. So let's see. So the next set of direct testing is PCR. You've heard a lot about PCR. A lot of people love to use PCR because PCR actually detects very small amounts of DNA or pieces of the bacteria. And what they do is with this very small piece of bacteria, they can actually amplify that and make a bunch of it to where you can really see it. So this microscopic piece can then become quite plentiful to where you can do a lot of studies on that. Now, PCR does require what's called a primer. So a primer is this specific thing that, that attaches to that set of DNA that you have in a sample. Now, when we talk about strains and species of Borrelia, these primers only look at one strain of bacteria. And if you recall, there are over 300 strains of Borrelia bacteria worldwide. So if you're infected with a Borrelia species or strain that's not specific for that one commercial strain, you most likely aren't going to get a positive PCR test result. So that's kind of the downside of a lot of this testing. We're using these commercial test kits that look at these different, or that look at usually one strain of the Borrelia bacteria. Again, this technique, it is very specific. So if you can PCR a bacteria, it is there. The con of this is that it has very low sensitivity, so it means there are a lot of false negatives, and again, that usually comes down to the fact there are over 300 strains of Borrelia bacteria, there are a bunch of different species, and the commercial primer used in most lab kits only look at one strain. So another type of direct testing is a dot blot. This is a very simplified version of a Western blot. The most common things that we're seeing now are urine collections. They're really easy. You collect urine and you basically look to find pieces of the Lyme bacteria or the Borrelia bacteria. And then in the lab, you add some antibodies on top of that. And in essence, you're supposed to create precipitation, which adds color to the sample. So if you can see a colored sample, it's a positive test result. And again, if you have Borrelia bacteria and it's attached on the membrane and you add an antibody that's not specific for it, you're going to have a negative test result. So another type of direct testing is fluorescent in situ hybridization. Ultimately, you have these fluorescent probes that bind to DNA and will light up if you have it. This is a very specific technique, but again, the commercial test kits might only use that one strain of bacteria, so you really have to get this done through a very specific lab. So a lot of the tests that I've showed, these direct testing techniques, though they're very specific, oftentimes they're very low sensitivity, so you might get a lot of false negatives depending on what type of bacteria is present. So a little bit about indirect testing. So we have the Western blot. You've heard a lot about Western blots. So with indirect testing, you are looking at what is the immune system seeing. And again, the immune system changes, as we know, even between women and between men and between the different forms of Borrelia bacteria. Western blot, it uses electrical currents and it separates proteins by size. So whenever you see the 18 kDa, that's an 18 kilodalton protein, that's a molecular weight. So it goes from the smallest protein to the biggest protein. And those are all little pieces of the Lyme bacteria is how you can think of it. So what you're looking at are you producing antibodies against pieces of those Lyme bacteria? And if you are, it lights up in the Western blot. So in that image on the right side, you can see that's a nice control. So those kind of dark colors you are making antibodies against pieces of that Lyme bacteria. On the left side, you can see other samples where maybe they're only reacting with a few of the proteins. So this is a really great test. This is actually what I use a lot in our practice because the classic Borrelia bacteria prefers to be in tissues. And so when you're doing a blood test or you're taking blood, it's a lot easier to look for antibodies rather than a needle in a haystack. So unfortunately, this really does rely on the host immune response. And as I'll talk later, the longer you've had the infection, oftentimes you're not producing a very strong immune response. So the testing can be quite negative. Also, if you have co-infections, those co-infections I mentioned earlier, they can actually distract your immune system to where your immune system focuses more on these co-infections and kind of doesn't react very strongly with the Lyme bacteria, so you can get a negative Western blot here. So let's talk a little bit about the ELISA. So ELISA, again, you have so antibodies, which again are immunoglobulins, are placed within wells and then bind to a prepared antigen. So you can see in the picture the yellow triangle, that's a prepared antigen, so that's basically a prepared Lyme strain of bacteria in the lab. And then you can react your own serum against or your own antibodies against it and see if it binds. So again, it really depends on, do you have round body form? Do you have the Borrelia form? What species of Borrelia do you have? What strain of Borrelia do you have? So again, this testing, though it's very specific, it has very low sensitivity. Again, it's a quantitative value. So most laboratories also use something called a whole cell Sonicate preparation for Borrelia burgdorferi. So there's a lot of other cellular components in there. So it may actually inhibit the binding process, and that would produce a negative test result. So then we have an immunofluorescent assay. So this looks for antibodies in patient serum. So Joshna Shah actually talked a little bit about this yesterday. And what you do is you have a slide with your pathogen or bacteria on it, and you can then react, again, antibodies on it. And if the antibodies stain, they can actually produce fluorescence. So when you go back and look under the slide, the bacteria might glow if the bacteria are present. But again, this all comes back down to strains, species, versus the commercial kits being used. So these are some other types of indirect testing I like to utilize because it can also give you a clue as to what else is going on. So the CD57 natural killer cells, you've probably heard a lot about these. These are a type of white blood cell. They are a subset of lymphocytes. They actually are considered a marker of Lyme disease. So normal is greater than 60, and a lot of Lyme patients present with numbers less than 60. There are only 2 other conditions that we know of that will cause a low natural killer cell count. So specifically the CD57 count, and that is tuberculosis and autism. So it's kind of interesting because there has been a link between Lyme disease and autism, so you wonder if that maybe play a role there. And again, with the female to male ratio, females tend to have a lower natural killer cell count than males do. Now, it's interesting, in HIV and AIDS, the CD56 natural killer cell is actually used as a marker of that disease. So again, the natural killer cells, they're very useful, and you can think about it as a marker for Lyme disease. Now, if they are in normal range, that doesn't mean that you don't have it. It's just it can really help clinicians out. Tuberculosis. Yeah, so we had a patient in our practice who did not have Lyme disease, but indeed had tuberculosis and a low natural killer cell count. So So the C4A level is another great test to perform. It's another indirect test, and it's part of your complement cascade. The complement cascade gets released in response to infections. It is a general marker of inflammation. This is not specific for Lyme disease, but oftentimes patients with a lot of symptoms can have a higher count as well. So normal is less than 2,800. I've seen patients with counts as high as 84,000 before. Again, females tend to have more inflammation than males, as you can see by the ratio down below. Okay, so hopefully I didn't put you to sleep, but so as far as test results, okay, so the biggest question I get, well, why are my test results negative? I have Morgellons disease. I've heard it's associated with Lyme disease, so why are my test results negative? So just to kind of recap really quickly on what we've already gone over. First of all, Borrelia, especially the classic Lyme bacteria, Borrelia burgdorferi, it likes to be in tissues. So the whole sensu latu group that we talked about earlier, it prefers to be in tissues. So when you're doing direct techniques from a blood sample, it is very difficult to find using PCR techniques. So that's again why I like to use indirect techniques for looking for these types of bacteria. The length of infection does play a huge role. The longer you've had the infection, oftentimes your immune system can kind of forget about the infection and not produce a strong immune response, to where if you are looking at the antibodies, they may oftentimes not be there. And that's why it's so important to do those other tests like the natural killer cells and the co-infection testing as well. Borrelia, again, has a lot of pleomorphic forms. So depending on what pleomorphic form you have, you may be eliciting a different immune response. Again, there are a lot of species and strains of bacteria out there. And as we talked about, the commercial test kit only uses one lab strain of Borrelia to react your blood with. And if you have one of the many other 300 strains out there, it might be unlikely that you'd cross-react. And it all depends on how good the test is that you're using as well. And again, there's the gender bias. Men might test more positive than women, so that factor plays a role. And also the wrong test may have been ordered or the wrong kit may have been used. So again, that kind of comes back into sensitivity and specificity. You do have to be aware of how good the test is that you are using. There are a lot of new and emerging tests coming out right now, and most of them don't have published literature on sensitivity and specificity. So I just want to make that very clear. And finally, co-infections. So co-infections, if you have a co-infection, so those are the other bacteria you can get from a tick bite or other viruses, they can actually distract your immune system to where you may only see positive reactivity against these co-infections and not the Lyme bacteria. So what I always tell my patients is, if you tested positive for a co-infection, guilt by association, you have Lyme disease. And so once you get rid of the co-infections with treatment and you start treating the Lyme disease, you will see the Lyme test become positive over time. So now just getting into the CDC testing, there is such thing as a bad test. So let's talk about the CDC criteria. So the two-tiered testing for Lyme disease. So this is a commercial test kit that's available at any lab. So if you went to your family doctor, dermatologist, infectious disease doctor, this is what they will order on you. And it is an Elisa, so that indirect test we talked about, followed by a Western blot, another indirect test. So it's interesting. So testing is not recommended within 4 to 6 weeks of a tick bite because you're not eliciting a strong immune response at that point, according to most immunologists and infectious disease specialists. And then once you do perform the testing after 6 weeks, this test is still insensitive. It's less than 50% sensitive, and there are some studies showing that it could be as sensitive as 20%. So that means lots of false negatives. And just to give you an idea, HIV testing is 99% sensitive. So, and this is their commercial test kit available for HIV. So what's going on here with Lyme? Why do we have such terrible tests for Lyme disease? So this is the algorithm that the CDC recommends. So on the left side, you can kind of again see there's the EIA or ELISA screening test or IFA. So let's follow to the right and down where the red is. So let's say you test negative on ELISA, which we've already discussed. It's very low sensitivity oftentimes, so you can get a lot of false negatives. So if you're negative for that, well, sorry, got to consider another diagnosis or maybe retest it another time. Let's say you did test positive with that screening test. If you tested positive with that screening test, if you've had symptoms for less than a month, you can test for IgM and IgG antibodies with that Western blot we talked about. Now, let's say you've been symptomatic for over a month. Nope, sorry, you cannot look at the IgM antibody. You can only look at that IgG antibody because, again, they think IgM is only present in the first month of an infection. And if you were to have a positive IgM response after having symptoms for over a month, then, oh, sorry, it's a false positive. You don't have Lyme disease. I don't care if you have symptoms, but nope, it's a false positive. So just remember, you can have chronic IgM and or IgG throughout the course of the infection. This is your immune system. Your immune system does change on a regular basis. One day it could be negative, the next day it could be positive. So it's so important that when you do find a clinician to do regular follow-up appointments with them so they can continually order repeat testing because you will see these ups and downs during treatment. So another issue with the Western blot that the CDC uses and why you see so many false negatives is that so the CDC, again, uses surveillance criteria, and so if you actually look at this image here, you'll see 2 IgGs and 2 IgMs, the right IgG and the right IgM. That's what the CDC looks at. So the CDC wants 5 out of 10 bands for IgG and 2 of 3 bands. Now, if you note, they've completely eliminated the 31 and 34 band there. Because they think it could cross-react, and these are highly specific bands. So if your immune system were actually reacting against these pieces of the Lyme bacteria, that's quite significant. But oh wait, the CDC doesn't care because you may actually be cross-reacting, or some people may be having a response if they've had the vaccine before. So again, that's why their Western blot is so horrible. So this kind of looks at sensitivity and specificity of the commercial 2-tiered testing in late-stage Lyme disease. So these are a bunch of different studies that evaluated it, and you can actually see the sensitivity and specificity. So again, specificity looks at false positives. So again, high specificity is really, really good. So specificity is great for this, but look at the sensitivity. It ranges from 18% all the way up to 67, I think I see. So that's horrible. That's almost less than 50% sensitive on average as far as sensitivity. So that's lots of false negative tests. And yet this is what is recommended. So I do want to point out that there is a myth of high sensitivity. A lot of the papers being published by CDC affiliates or IDSA affiliates talk about that the 2-tiered serologic testing sensitivity could be as high as 87 to 95% for late-stage Lyme arthritis and neuroborreliasis. So that kind of goes against what we've learned thus far. So how do you test for sensitivity? Well, what they do is they take a group of patients who are required to have Lyme symptoms. So here are a group of patients with Lyme-like illness, and they have positive Lyme serology. So these are patients who are symptomatic and already tested positive. Then they test them again, and guess what? They're positive, so that's why they have such high sensitivity. So it's kind of this circular reasoning, and we really need to get out of that. So CDC is now coming out with new recommendations for testing. They're proposing a 2-tiered ELISA or EIA approach with a whole cell sonicated EIA with reflex C6 EIA. And we've heard some mentioning of C6, and I'll talk a little bit about that. But they're claiming that it has higher sensitivity for early Lyme disease, 61 versus 48. And let's think about the HIV testing, which is 99. And so again, they're saying it still has the same specificity. And again, I do want to point out the whole cell Sonicates contain really a lot of cell content. So you get a lot of allosteric inhibition. So antibodies can't react with antigens. You get a lot of false negatives. So what is the C6 peptide? This is just kind of a brief little breakdown. So the C6 peptide, it's this region on the VLSE lipoprotein. A lipoprotein is a protein of the Lyme bacteria. It's considered the variable major protein-like sequence expressed lipoprotein. And these antigens, or these kind of lipoproteins, are highly conserved and immunogenic across all Borrelia species and strains. I have to say, much more research is needed. We had a patient who also had tuberculosis and was testing positive for C6, and nowhere could we ever find Lyme bacteria, and he'd gone to about 20 Lyme specialists over the last 5 years, and nobody could find Lyme, and it turned out he had tuberculosis and a positive C6. So again, we still need to do a lot more testing, look at cross-reactivity as well. So now let's just compare Lyme and HIV testing. You've heard me now mention this a couple times. So HIV testing, highly sensitive and specific. The sensitivity and specificity both range in the 99 kind of range. Cook and Puri just published a paper beginning of this month called Application of Bayesian Decision Making to Laboratory Testing for Lyme Disease in Comparison with Testing for HIV. Bayesian decision making, it's kind of a probability, so it looks at the probability of how you will test. So in this paper, they found that in late-stage Lyme disease, so a lot of patients with Morgellons disease have kind of this late-stage Lyme, the two-tier test generated over 500 times more false negatives than the two-step HIV test. So again, this is horrible testing that's commercially available. Lyme disease testing in early-stage disease generated 56 times more false negative test results than HIV testing. And when there were neurologic or arthralgia symptoms present, Lyme disease testing generated 180 times more false negative test results than HIV. So here we have a disease that has wonderful testing, and then we have an epidemic on our hand with horrible testing. So something really needs to change. So this slide, you can see it kind of laid out a little differently. On the left side, you'll see Lyme disease testing. On the right side, HIV testing. You can also see, let's see, the probability of false negative results. And then let's see here. So you could see in the first stage for HIV, it's about 98, 98, 99. Second stage, 98, 98, 99. And then if you go back over to the Lyme disease area, it's 34, 33. So, I mean, it's just awful, awful testing. So this is a really great picture, and it also shows you, we're exploring all these different options for Lyme testing. So again, let's look at the sensitivity. So the C6 peptide ELISA that the CDC is now going to maybe start recommending has a sensitivity of 53%. And it may have a specificity of 92%, but got to get that up there a little bit. The classic ELISA, 62%, Western Blot, 62%. And then look at the wonderful HIV test available, 99% sensitivity, and specificity is 99 as well. So kind of summing up, so what do we recommend as far as testing? Well, let me first tell you what the CDC recommends. The CDC recommends FDA-approved tests only. So this is from their website. The 2 steps of Lyme disease testing are designed to be done together. CDC does not recommend skipping the first test and just doing the Western blot. Doing so will increase the frequency of false positive results and may lead to misdiagnosis and improper treatment. New tests may be developed as alternatives to one or both steps of the 2-step process. Before the CDC will recommend new tests, their performance must be demonstrated to be equal to or better than. So they could still be equal, so they could still be just as crummy even if they develop new tests. And they must be FDA approved. So just to clarify one thing, there are no FDA approved tests for Lyme disease. I think the CDC needs to reword some of their website. There are only FDA cleared tests for Lyme disease. And again, the new tests that the CDC will create, they only have to be equivalent to tests previously cleared. So that's really not giving any kind of headway. Yep. So thank you, CDC and IDSA. So what do we recommend? So what does the Charles E. Holman Morgellons Disease Foundation recommend? What does LymeDisease.org recommend? What does ILADS recommend? We recommend a CLIA-approved lab test that specializes in testing for tick-borne disease and reports all bans on the Western blot. So CLIA is Clinical Laboratory Improvement Amendments. CLIA is regulated by CMS, which is the Centers for Medicare and Medicaid. So you really also have to make sure that the laboratory being used, that you're deciding to get your blood work done at, has published literature on specificity and sensitivity as well. Okay, so you have a negative test result, so now what? What do you do? So you need to start treatment. So when you start treatment, you oftentimes start stirring things up, and you may start producing an immune response. So you do have to start treatment. So find a clinician through the Charles E. Holman Foundation and retest. I have seen patients completely negative for Lyme disease for 2 years straight, even though I test them every 3 months. And again, it also depends on co-infections. So make sure you're also getting tested for co-infections and make sure you're treating those co-infections as well. So in conclusion, so there are many limitations with the existing tests. So again, sensitivity and specificity, we've learned that most tests available for Lyme disease are poorly sensitive. It depends on the antigen and primers being used. We kind of talked about all the different Borrelia species, all the different strains out there. Again, there's now the relapsing fever Borrelia, which is a completely different group of bacteria. Again, there are bad tests. We have the CDC criteria. And again, there are a lot of different variables that can also influence the test results. So again, species, strain, the pleomorphic forms we talked about, the gender bias, co-infections, and the length of time with infection. And again, test results do change with treatment. So you have to start treatment and then retest. So we're not doing that. So I want to thank Cindy Casey and the Charles E. Holman Foundation for their continuing efforts, and thank Marianne Middleveen, Dr. Stricker, and thank you to all the presenters here, and thank you to all of you out there and patients afflicted with Morgellons disease. Here are my references.